So good morning, welcome to this session. My name is Oliver Gröner from Optimedis and I'm the chair of this session. My apologies, my voice left yesterday. I got a cold and this is what's left of my voice, but I don't have to do the talking anyway. We've got a couple of speakers. The bad news though is that it appears that two of my speakers are missing. So I'm still missing for Gabe Orthus, and for the last speaker, Karina Dantas. So please do come to see me if you are in the room. If not, we have to start anyway. And I'm very pleased to introduce my first speaker, Professor Isabelle Peytremann Bridevaux from Lausanne. And she will talk about financial barriers to decrease the benefits of interprofessional collaboration. It's a large study conducted in Switzerland, and I'm very pleased to welcome you to the floor, and the floor is yours.
So good morning, and thank you very much for giving us the opportunity to present our work that I will be presenting on behalf of Ingrid and Jill, who conducted the work, presented the results, but could not make it to San Sebastian today. So, as you know, interprofessional collaboration is a key element of integrated care, and according to the WHO, it occurs when multiple health workers from different professional backgrounds provide comprehensive services by working with patients, their families, carers, and communities to deliver the highest quality of care across settings. And in fact, interprofessional collaboration is a process of experience sharing, which includes shared decision-making, for example, communication, and shared knowledge and skills. And it should lead to both improvements in patient care outcomes and to improvements in organizational aspects of care, such as collaboration, coordination between healthcare professionals, or job satisfaction and engagement. Research has also shown that improving organizational aspects of care is associated with better patient outcomes. It's therefore expected interprofessional collaboration to be beneficial to integrated care initiatives. Implementing interprofessional collaboration remains difficult nevertheless, and several barriers are known. For example, time pressures or lack of time, inequality in decision-making between professionals, role definitions, and funding issues. And actually, the interprofessional collaboration literature often focuses on education training or on implementation within hospitals, implementation within ambulatory care or within integrated care initiatives is more rare, and actually more information is needed about the mechanism underlying the implementation of interprofessional collaboration within those two latter settings. Indeed, whether barriers to integrated care impede or undermine the effect of interprofessional collaboration has rarely been examined up to now. So in that context, the aims of our study were first to explore whether the degree of development of interprofessional collaboration was indirectly associated with patient care improvement via organizational improvements, and second, to understand if barriers to the implementation of integrated care hinder those improvements. And this is illustrated in the figure below, which shows a moderated mediation model that we tested. So, in other words, we hypothesized that the degree of development of interprofessional collaboration would indirectly result in patient care improvements via organizational improvements, leading first those improvements before having an effect on the patient at the patient level. We additionally hypothesized that this indirect effect would depend on whether or not barriers were present, with the presence of barriers leading to less improvement at the organization level and thus also less improvement at the patient care level. So this means that the beneficial effects of interprofessional collaboration would be less in case barriers were reported. For this work, we used data from the Swiss Integrated Care Survey that we conducted between July 2015 and 2016 in order to identify and describe all the integrated care initiatives in Switzerland which met our inclusion criteria, which were the following. These initiatives needed to have some kind of formalization of integrated care principles. needed at least 2 levels of healthcare services, for example, hospital and private practice, or hospital and pharmacies, at least 2 different groups of professionals, and needed to be ongoing during the survey. We identified 176 integrated care initiatives at that time, and we conducted secondary cross-section analysis on data reported from the main representatives of 153 initiatives, which were not sub-programs of larger ones and which targeted patients' components. The different variables that we included in our models were the following. First, we had the degree of development of integrated care, of interprofessional collaboration, as measured by a mean score of 14 items adapted from the iCare4U project. Then organization improvement as measured by a mean score of 4 items, including, for example, professional coordination or professional satisfaction. Then outcome was the patient care improvement measures as a mean score of 6 items on that level. And finally, 11 items representing different barriers that were divided into professional barriers, patient barriers, and financial barriers, for which also mean score were calculated. All these items were measured on a 4-point Likert scale, and all Cronbach alphas were higher than 0.7. We also considered the following variables, other variables, those to describe the integrated care initiatives in black, and those others who were considered to be confounding variables. Indeed, we could say that the degree of development of interprofessional collaboration could depend on whether or not, for example, the initiatives were more or less supporting interprofessional collaboration, also on the fact that these initiatives had already several groups of professionals working together. We performed moderated mediation analysis with this data, and in order to facilitate now the understanding, I will just divide them into 2 steps. First, the mediation, and then the moderated mediation tests. So mediation, in fact, tests the indirect effect of the predictor on the outcome through the role of the mediator, and against the direct effect of the predictor on the outcome. And mediation is confirmed if this indirect effect is significant, while the direct is not anymore when introducing the mediator. And now the moderated mediation test. The latter is confirmed if the mediation test is existent and if the interaction between the moderator and the predictor on the mediator is significant. The power analysis that we conducted concluded that we had a large enough sample size to conduct this moderated mediation analysis. Now some results. So first, here you can see that these integrated care initiatives were spread across Switzerland, and that there was an increase in their implementation in both the French-speaking and German-speaking part of Switzerland after 2004. These initiatives could be divided into 5 main categories. Those initiatives targeting specific patient groups, for example, patients with specific chronic diseases, or the elderly, or patients with complex needs. They were divided also in those initiatives targeting only mental health and psychiatry, initiatives representing physician networks or health centers, initiatives targeting or specifically focusing on transition and coordination, and a few initiatives that were only tackling drug treatments. Most of the initiatives had components targeting the patient and the healthcare providers, and the most often involved healthcare providers were physicians and nurses, and then other paramedical professions and social workers. Now, results of the Step 1 mediation analysis. This analysis shows that the direct effect of the degree of development of interprofessional collaboration on patient care improvements disappeared, in fact, when the mediating role of organization improvements was considered. Or in other words, the more representatives of the initiatives reported interprofessional collaboration, the more improvement at the organization level were seen, which in turn were associated with more patient care improvements. And now the Step 2 moderated mediation analysis. This highlights the fact that the mediation was not moderated by professional or patient barriers, but by financial barriers only. In other words, the beneficial effect of interprofessional collaboration disappeared when financial barriers were reported. And actually, if we could look more closely at the interaction effect, we can see that the more financial barriers were reported, the less interprofessional collaboration was associated with organizational improvements. So, as in all studies, we have some limitations to acknowledge, and here we mention two. First, the fact that the data was only self-reported, which may have introduced social desirability bias, and the other, the fact that the cross-sectional study design prevents causality ascertainment. Okay, so now as final words, our exploratory results show that the beneficial effects of interprofessional collaboration on patient care outcomes are not direct, but pass through organization improvements. And this complements the literature about the positive impact of interprofessional collaboration on job satisfaction and work and well-being by suggesting that improvements in work environment and organization aspects of care are necessary for interprofessional collaboration to improve patient care. Our exploratory results also show that financial barriers hinder the beneficial effects of interprofessional collaboration. The implementation of interprofessional collaboration in practice requires initial financial resources, and this forefront investment is key since the success of integrated care initiatives, including interprofessional collaboration, seems to depend on it. Thank you very much for your attention.
Thank you very much for this presentation. This room is not ideal to facilitate interaction, but we do have time for questions, so please, are there any questions from the floor? I assume we have a microphone somewhere. Any questions? Over here and there, but no microphone. It's coming. Just a moment, the microphone is coming.
Thank you. Thank you for the presentation. It was very interesting for me. I was just curious about how do you measure patient care improvement?
There was a list of different, there were patient satisfaction, it was patient, sorry, I don't have the light. It was patient-centered care improvements, such as patient satisfaction, involvement of the carers, of the family, and others. I have the list here, I can give it to you.
Okay, thank you.
Thank you as well. Can you talk a little bit more about the type of financial incentives you put in place that were part of the change? What was there? At what point did you introduce these that were assessed in the change?
We did not introduce these. Were reported financial barriers by the representatives of the initiatives.
So what financial barriers were they talking about in terms of the billings from the physicians, or was it from patient-related?
There were, I have them here, it was different. There were, I think, 3 barriers at the patient level, 4 on the professional level, and 4 on the financial levels. You mean you are talking about the financial ones?
Yes, I'm curious around the type of barriers that they were.
I will give them to you just after I have the list.
Thank
here.
you.
Is that on? Yeah, thanks. Harriet Hiscock from Melbourne, Australia. Was there anything in the surveys where they said what the types of organisational improvements were that really was associated with the change?
This was the first survey that we had conducted in Switzerland. It was very brief, quite relatively brief, and so we did not have so many information about all the details of the interventions. That was a limitation, but we first wanted to know how many were there, because we have not very much data in Switzerland about integrated care. So it was a first shot, and some brief descriptions about the initiatives. The problem is also that these were given by the representatives, and how much this truly fits to the reality in the field is questioned.
Another question about the financial incentives. Could you describe what these actually were, and maybe it wasn't part of the study, but do you have any thoughts about how well these were working?
I have no idea because we didn't ask these questions we don't know how they were working or not. We didn't have this question to the representatives.
But can you say what they actually were? Was it funds paid for, how did they work?
I said before, I don't know how they worked. And I have the list. I just don't have this on the top of my head now, but I will give to you the 4 incentive financial barriers that we had.
Any last question? If not, I've got a last question, because you mentioned of the 153 initiatives, they were very heterogeneous in terms of by whom they were led and what the focus were. How did this heterogeneity impact on the analysis? Presumably with the sample size you were not able to conduct any subgroup analysis, but if so, what does it mean to have such a heterogeneous group of initiatives pooled together and conduct an analysis on this group?
It's true that I cannot answer because we had only 153, so we did not perform subgroup analysis. We introduced a number of healthcare professionals also as a confounding variables. Yeah, we could have done this. I don't know how much this would have changed the results.
Okay, thank you very much. You mentioned it's the first time you conduct the survey, so hopefully there will be future surveys of this kind, and I think the question shows that there's an interest in this type of study. So thank you again. Please join me in thanking the speaker again. And I really apologize